Okay, so I wanted to do a little video to give you guys a little bit more details on respiratory management for our clients. So I've got a few things that I wanted to share with you guys. So we've talked a little bit about inhalers and spacers. So they come in these little canisters. You have to take the cap off. It has a little prong push part that goes into its little push part. These aren't the actual names, but whatever. And then push down, and it immediately gives out that medication. So they have to be very coordinated, push down, and inhale in order to get the full effect of the medication. So that is why, with especially young children and older adults, that using a spacer can be helpful. Remember, almost done. Right? So a spacer will deliver that medication into this chamber, hold it in there until they can appropriately pull and suck in. So it gives them that little bit of extra time, hold all the medication so they can still get their full effect of the medication. This is what this is Advair, so this is like a home version of some of the inhalers. Maybe look like this. They have a little ticker counter. So this one is of course 0, so it's empty. This one. And so then this is their mouthpiece. They put it on their mouth, and then they do this instead of, but it still involves that coordination. However, these ones, of course, do not fit into the spacer. So when this comes out, this does not fit in there. So that is one of the parts of the education that we need to make sure that their inhaler will fit a spacer. All right, so we talked about a spirometer. This is a Spiroflow. So this is a version of a spirometer. So this is different than an incentive spirometer. This is, so incentive is incentive as in benefiting the client. So that's inhaling. So trying to inhale to promote that opening of the lungs. Whereas this is testing their capacity. So how much are they able to blow out in order to measure. Sometimes we use both to kind of give a good estimate of the difference there. So this has little markers that we can put the green area, the red area. Your book talks a lot about this red area, what it means for the client, things like that. So I'm going to try to do it and hopefully not screw this up. So now it hits my patient marker and I'm in that green range. You don't need to know the normals. You just need to know what it means if they suddenly are not able to hit their expected normal. Also, we have a nebulizer. So typically this comes in different pieces. In its little bag. So how do you put it together? So you have your oxygen tubing, you have your nebulizer piece and cap. So sometimes this will come on it, sometimes it will not. This is where we put the medication. So this is the difference between a nebulizer albuterol versus an inhaler albuterol. So this nebulizer comes in a liquid form. So we open it up, we pour it into this area. It fills up. Close it, but it will still leak through the top sometimes and through the edges. So it's very important, especially in the mask versions of the nebulizers, that they keep them upright so they don't lose part of their medications. Then you have your T-piece with the mouthpiece and the exhale part. So you attach it to the top. This for their exhale. And then the oxygen goes through the bottom, nebulizes that liquid, aerosolizes it, client inhales it and exhales. So we would like for them to also exhale through here. So it channels it and focuses it. That way they're fully exhaling it, their CO2, and not retaining anything. So they keep going until all that liquid is aerosolized and the breathing treatment is done. So we'll no longer have a mist going on. So their treatments may last 20 minutes, 10 minutes, somewhere an hour. Just depends on the type of medication, how long it takes to aerosolize, and how long we want that client to get that medication into that area. The last thing I want to talk about is the thoracentesis. And watch out, baby. Watch out. Put this right here. Thoracentesis and chest tubes. So thoracentesis being that there's fluid in that pleural space that we want to get off so that they can breathe better. I need to put this back together. Yes, Lily. You want to go? Okay. I'm just going to go back in because I took it all the way out for the first video, and the first video did not work. Anyways, so this is thoracentesis tray. It is a it's considered a surgical procedure, but can be done at the bedside. So it still requires a surgical timeout. It involves a needle. It is a fairly large needle, as you will see, but it also feeds over itself just like those IV needles. So when you take the needle off, the catheter is left in its place. It has multiple little holes on the side so that it will drain that fluid. So we only want this initial puncture. So this can be scary sometimes to patients because they see this really long needle, but this whole thing is not going in there, just the tip to get in through that skin, through it, and it is numbed. And then the rest of this, or a part of this, is into that space, at least until this little marker. Usually most of them have them in order, and this is hooked up to suction or hooked up to a suction canister to remove that fluid. Sometimes rather quickly, sometimes we want to do it over a slower period of time. If this is just a quick occurrence that happened due to inflammatory infectious process, then sometimes we can just remove it. If it is something that is due more long-term, like cancer related, that there's continuing to output this, we might look into something more permanent instead of just a one-term thing. In the hospital setting, we could do a chest tube. So it's very similar procedure. We put it in, you take out the needle, but then this is stays in place. Usually we use one that has like a little pigtail or something that is less likely to pull out of that skin. Sometimes we'll also suture it, but it's basically the same type of procedure, but it's left in place. And this part is connected to a chest tube. Now, it is important that since we are pulling things out, we don't want anything to go in. So always hooked up to suction or closed off. And then also a site that could be a reason for going in is going to be the client's skin site. So we want to make sure that is completely closed. It is skin tight. We will use sterile gauze or Vaseline gauze so that anything that is trying to suck in, it will pull in that wet liquid. And then, so also the same kind of issue with chest tubes that are for air. If there's air in that pleural space, then you're inserting it and pulling it to suction, and then say hi. And then you are trying to make sure that air does not leak back into that space, causing the same problem that I just did. So that pneumothorax. Alrighty, I think that is practically it. Don't touch that, baby. There's needles on the table that can hurt you, okay? That's why mommy wanted you to do this at the work, but at home. All right, let me know if you have any problems or concerns. We will discuss some more of this in the lecture as well in the Q&A session tomorrow without my daughter. All right, thank you guys.